Mike Gibson, Marc Bonaca, and we are talking about CCTA, looking at coronary arteries using CT angiography. Mark, I'm kind of old-fashioned. I like to, squirt dye down arteries and, look at it directly. Talk to us. Why in the world would we need a CT instead of the angios that I do? Are you guys trying to put me out of business?
No, not at all. But I do think that our understanding of the biology and the pathobiology of coronary disease has evolved, and certainly angiography is important, and stenosis, ischemia, those things are important when we think about symptomatic patients, certainly in the setting of an acute coronary syndrome. But what we've learned is that plaque is the disease, and the biology is more than just sort of what we see from the lumen. We have to see the vessel wall and the plaque itself to really understand risk and how to modify it.
Yeah, a guy like me is just putting dye in the artery, looking at the artery and the plumbing model. There's a blockage in the plumbing. I will fix it. But it's so much more than that, right? I mean, it's what's blocking the plumbing. We don't really, unless we use some very fancy tools, don't really get to look inside the plaque.
That's right. I mean, and we've learned that it's not necessarily the most severe stenosis that's going to rupture and lead to a myocardial infarction. And so there can be people who have, relatively benign looking angiograms that can go on to have an MI, and people who have stenosis actually calcified and stable. And so if the goal is to prevent events, we have to understand, the nature of the plaque. The same way when we treat people with cancer, we do biopsies, we understand the nature of the disease. I think plaque biology is really where we're going for it. And, I think it's particularly relevant, when you're doing your angiograms, people are symptomatic, but about half of people who die of a heart attack won't even know they had coronary disease before their first event.
Exactly. So screening is becoming more and more relevant. And we have some fancy tools in the cath lab to see, is that blockage, is it functionally important? Is it really limiting blood flow? But that may not be the one that kills you. It may be the one that is less severe, that isn't limiting blood flow, that's full of fat. And when it ruptures, you're going to have a heart attack.
That's right. I think and both are important, but I think particularly in the setting of prevention where people are asymptomatic, that doesn't mean you don't have a problem that needs to be managed. And I think for symptomatic patients, it's both. Knowing the flow, FFR, and all the amazing things you do, Mike, but also understanding, maybe what the plaque biology is, and what other pharmacotherapies could be deployed to deal with that.
So, talk to us about how CT can help in offering a good assessment of someone's prognosis.
Well, yeah, great question. There've been several studies that have looked at, CT angiography and management, Scott Hart, Promise, others, and we now know that plaque is correlated with outcomes, or is strongly prognostic, and not just plaque, overall plaque burden, but non-calcified plaque, and that people who have more non-calcified plaque are more likely to have higher risk, even in the absence of stenosis. So, it gives us an ability to prognosticate. And if you think about it from a prevention standpoint, what we do with our risk scores like ASCVD is we're largely guessing based on fairly crude predictors rather than sort of looking at the disease itself. And that's where I think from a prognosis standpoint, CCTA offers a lot of hope.
So, offering prognosis, but we want to do something about it, right? I mean, so it helps. How does it help guide therapy? And what's the data that suggests that using it as a trigger to guide therapy improves outcomes?
Yeah, great question. I mean, there have been trials, as I mentioned. Scott Hart, showed a reduction of myocardial infarction, and not everyone there necessarily changed management, but there was a shift in management based on the findings of the CTs. There are other trials that have shown potential benefit, and I think, you know, the notion here is we have drugs that can modify plaque. We have lower LDL targets. We have antiplatelet therapies, antithrombotic therapies, now GLP-1s and other things as well. And so the concept is that if you see a high burden of non-calcified plaque, that we can, intensify treatment to modify that plaque. Now, there is a prospective trial going on to look at that from an outcomes perspective called Transform. And I think that would, in asymptomatic patients, be an additional data point to support the use of CCTA, not only to prognosticate, but to guide treatment.
And you said something critical a minute ago, Mark, that there may not be any severe blockage there. We're just talking about all that fat that's everywhere there in the artery, and we can perhaps change someone's course by treating them. So, Mark, how are you using this in everyday practice?
That's a great question. There's a lot of variability out there. I mean, the guidelines right now support the use of CCTA for symptomatic patients, for those with chest pain. This isn't recommended by the USPTF or others for screening in asymptomatic populations because we don't have that evidence yet. So we're doing a lot of coronary CT angiography. I'm sure you are too, in the setting in the hospital and patients with chest pain to support planning for PCI. In the preventive realm, in the outpatient setting for asymptomatic patients, more variable because we have to acknowledge that we don't have prospective data yet to support that. But I have to say, more and more patients come in and they want to know, they have high LPA, they've got a bad family history, maybe they're younger and they, are unlikely to have a high calcium score. That sort of power of zero, I think, is misleading, particularly for the young
Yeah,
patient, right?
I agree.
So I think more and more people are asking, they want to know, do I have something I need to manage? And I think, if you're talking to somebody in their 40s or early 50s and it's, do I take this drug for life? They kind of want to know whether they're treating something.
So you can't go on the internet or go anywhere without seeing the letters AI. AI is everywhere. How is AI being brought to bear on all this? Okay, so we have this CT angiogram providing information, but how do we integrate everything within it and patients' demographics, everything about their risk? How do we bring it all together?
That's a great question, Mike. Yeah, I mean, because you can order the angiogram and you can get the anatomy and you can see that there's some non-calcified plaque and so on, but it's really hard in one's mind to integrate that along with all the patient variables. And so there are tools out there. They're different. There's HeartFlow. There's clearly has an AI enhanced integrative model for the plaque biology. And so it's looking at the amount of plaque, the type of plaque, where it is, sort of color coded, and then it gives you a stage of disease. And so even for a sort of simplistic preventive cardiologist like myself, like it helps me communicate to the patient, this is what your risk is, this is your stage. And I think analogous to other diseases like cancer, again, is it, stage 0, is it stage 3? And that helps you align on targets, because otherwise I think it's really hard to take all that data and sort of put it in your head and figure out what to do.
Mark, give us a few key take-home messages and lessons.
Yeah, I think we're really at an inflection point, Mike, in terms of how we think about the number one killer, which is cardiovascular disease. I think we're going to move from a model of, treating and testing risk factors and guessing who has disease to a model of screening and targeted, personalized therapy based on, each patient's biology. And I think that's really exciting. The data need to be borne out. They're ongoing trials, but I really do believe in 5, 10 years we'll be practicing cardiovascular medicine in a very different way, really thinking about personalized medicine and prevention. And I think coronary CTA is going to be a core component of that. It's not going to take away the cath lab, but I think it'll maybe help us get the right patients to the cath lab at the right time. And maybe for people like you, knowing exactly what the anatomy is helpful. But yeah, I think it's an exciting time.
Changed my course. I got a CT and had a high calcium score, got a CTA, and have, not really that much in the way of fatty stuff, but it got me to get my LDL done. My LDL is 19 now. I just want to tell you.
That's
So,
awesome.
yeah, and I'm feeling great. Well, Mark, thanks for joining us. I always learn so much from you, and thanks for all you do in kind of moving this field forward.
Oh, thanks, Mike. Thanks for the opportunity. It's great to have a conversation about this, and thanks for the partnership.
Thanks.